At EBMT 2020, as the Chronic Malignancy Working Party of EBMT, we prepared a poster presentation which tries to analyze the impact of adding bortezomib to the conditioning regimen of melphalan 200. In general, melphalan 200 is the standard conditioning regimen, but it's well known that this does not prevent relapse, which is the main reason of failure after autologous stem cell transplant. So in the past, there has been attempts to improve conditioning regimen, either adding an alkylating agent or one of the novel agents, such as bortezomib, and there are small studies reported, and also prospective randomized studies, mainly coming from IFM. The retrospective study was in favor of adding bortezomib, but the prospective randomized study did not show the benefit. So in EBMT, we made a retrospective analysis based on more than 4,000 patients. And for the first time in literature, we are not only focusing on the first transplant, but also on the second transplant, with the aim to analyze the impact of adding bortezomib to melphalan. So within this more than 4,000 patient database, we have almost 300 patients who have received bortezomib-melphalan combination for the first transplant. And we have also 600 patients who received a second transplant. And of these, 256 were salvage and 318 were tandem transplant. Among these, we have 143 well-mel patients who received as a part of a second transplant, and thus we were able to compare the impact of the salvage versus tandem transplant and impact of adding bortezomib to first transplant or the second transplant. In short, the characteristics of patients in the first transplant, MEL200 versus well-mel, are not very different. Some have some favorable, some have unfavorable features, but in the end they are balanced. And the study belongs to the period which is during 2012 and 2016 with the transplant year, so that we have long-term follow-up to give us the overall survival and also PFS values. In regard to the differences in the conditioning regimen based on the response prior to the first transplant, patients who have achieved a CR or VGPR benefit the most. And if these patients have received MEL200 for the first transplant, they are doing the best. But if patients are in this situation for the first transplant, giving a well-mel-based regimen does not improve outcome. However, if the first response is PR, use of a well-mel-based regimen looks like to be the best. So improving the conditioning regimen by adding bortezomib seems to be more beneficial among patients who have a response which is less than VGPR. And in terms of the second transplant effect, we looked at patients who received MEL200 for the first transplant and compared between well-mel or MEL200 as a second transplant. In terms of overall survival or PFS, adding bortezomib to MEL did not improve the outcomes. On the other hand, it seemed that the survivals were better for MEL200. But if we dissect into the transplant reason, whether tandem or salvage, it was seen that in general, all patients who received a transplant as a second transplant for salvage purposes, their outcomes were worse than tandem transplant, which is expected. But those who received Valmel as the conditioning for a salvage regimen, they did better. So it looks like that adding bortezomib-melphalan in the first transplant is beneficial for those who do not have the optimal deep response VGPR or better prior to the first transplant. And secondly, those patients who need a second transplant for the purpose of a salvage transplant, adding bortezomib in this setting looks better than MEL-200 as well. Currently, our data is still under investigation, and we are hoping to improve our missing data in near future and hope to publish soon.